A very good evening to everyone. It gives me immense pleasure to welcome you all to the SATHI Smart Nursing webinar series, which is an initiative from Foxy, collaboration with Public Awareness Committee, the Young Talent Promotion Committee, and the Practical Obstetric Committee. We all know that nurses are the backbone of maternal and newborn health care, and their knowledge, skill, compassion, and timely intervention make a proud difference in the life of women and their babies. Through this initiative, we are strengthening the allied healthcare, and our goal is to empower every nursing professional with practical, evidence based knowledge that can be implemented immediately in day to day clinical practice. Today's module has both the soft skills and clinical competency, ensuring safer maternity care and better patient outcomes. We thank our associating society, the Kohima Obstetrics Society, for this association. And we also thank Dr. Lungan for
Power on.
coordinating this event for
Plenty
us.
mood.
We thank Dr. Bhaskar Pal sir, Dr. Suvarna Khadilkar madam, the Foxy leadership, and our three chairpersons who have formulated this program, Dr. Kevin and Dr. Thenjavu ma'am. We would request you to please say a few words after Dr. Bhaskar Pal sir's video is telecast. Sahiti, can we have sir's video, please?
Dear friends and colleagues, I am Dr. Bhaskar Pal, President Foxy. I extend a hearty welcome to all of you to this webinar, a series of webinars called SATHI on smart nursing, conceptualized by Foxy and AMOX. Three committees of Foxy, the Public Awareness Committee led by Dr. Malika Umbardan, the Young Talent Promotion Committee led by Dr. Rohan Palshirkar, the Practical Obstetrics Committee led by Dr. Rashmi Kahar, along with two committees of AMOX, the Public Awareness Committee and the Safe Motherhood Committee, are bringing this initiative to you. India has made enormous progress in reducing the maternal mortality ratio from over 500 to under 90 in the last 20 years. We still have some more distance to cover. By 2030, we need to bring it down to below 70, and the government of India aims to reach that goal by the year 2028. Obstetric care depends on a group of people which includes the doctors, the nurses, the technicians, the ancillary services, the sonologists and everyone. And we cannot make this progress unless all of us are on the same page. I am sure that this series of webinar would be very helpful in updating your knowledge, improving your skills, and will benefit the mothers of this country. Thank you.
Thank you, Sahiti. Can we have Dr. Kevin, sir, if he's around? Sir? Yes, sir.
Yes. Hello. Good evening, ma'am. Thank you so much for Foxy and the teams for organizing this CME webinar. It is a great pleasure for us to have this occasion, and I would also thank our speakers for coming forward to speak on this occasion, because it is through this active participation that we keep on learning new things. Yes, we have come across these topics and all in our life also, but as we keep on refreshing again, it becomes our habit. And through this again, the initiative is as such that to invite the nurses, the lab technicians, and all these things, it is a great idea, so that we all stand together to have expertise and active management of very critical uh, time. So I give my best wishes to all the Foxy and the initiative for starting such a wonderful program. Thank you so much.
Thank you, sir. Thank you for the association that the Kohima Society has with us. This is the first program in the Northeast and the 15th in the list that we have started since the International Nurses Day. Can we have Dr. Teja Vino ma'am to please share her views regarding the program? Ma'am, please unmute yourself. Am I audible? Okay. Ma'am, please unmute and speak. Tejavarna ma'am.
I think there is some network issue, ma'am.
Yes,
Ma'am,
ma'am.
you are audible now.
Now you're audible, ma'am. Ma'am, if there is some network issue, you can always share in the chat box also your wishes, ma'am, because it would be a good moment to hear from you. If you could speak, we can start, ma'am. If you can unmute. Uh, can we start with the program then, ma'am? Can I request Dr. Longan ma'am to please introduce our first speaker? We have this module into two parts. The first is the communication skill, and the second is the clinical skills. And both the topics would be discussed in the local language and English itself. If you have any queries regarding the topic, please put them into the chat box. And if there is any feedback, then also please do let us know.
Okay, thank you, ma'am. So,
Yes.
I think ma'am is.
You can start the presentation, ma'am.
Okay,
Yeah.
thank you, ma'am.
Yes, ma'am.
So we'll continue the program with the academic session. So today the first speaker will be Dr. Sunil sir. Sir will be speaking on the soft skill. Sir is a consultant in the Nikos Hospital and Research Center, Dimapur. So I welcome you, sir, and I request sir to continue the presentation, sir. Sunil sir. Sir.
I think Dr. Sunil is in the OT, so maybe.
Okay, so we'll
better
continue.
to start
We'll
the.
start the second session. Okay,
Yeah.
the clinical modules.
Yes.
Okay, so since that is busy, so we'll continue with the next module. So I welcome Dr. Apeli Sukhalu, ma'am. Pardon me, ma'am, if I have pronounced it
It's okay.
wrong.
It's okay.
Okay, and ma'am is the consultant at Nikos Hospital and Research Center, Dimapur, and ma'am will be taking on the clinical modules, ma'am. So I warmly welcome ma'am and request ma'am to continue the session, ma'am.
Thank you. The slides will be put up by.
Yeah, ma'am, I think. Monica, ma'am.
Yes, ma'am.
Ma'am, the
Saiti, if you could share the second presentation, that is the combination of clinical postbed, the episiotomy and preeclampsia.
Okay, ma'am.
Yeah. Ma'am, in the meantime, you can start your presentation. She will share the screen from her end.
Will the slides be shared, or should I share it from this end?
Slides will be shared shortly, ma'am. Please start the presentation meanwhile.
Okay. I will start the first topic on postpartum hemorrhage. Postpartum hemorrhage is a medical emergency, as you all know. It is defined as a blood loss of more than 500 milliliters of blood during a normal delivery, or 1,000 milliliters of blood during a cesarean within the first 24 hours of birth. It is an emergency, and hence keeping all equipment ready to handle such a situation makes it easier, and it reduces the risk of maternal mortality. So if in the labor room, a kit can be prepared which can be accessed within reach at the shortest possible time. It would be very helpful in reducing postpartum hemorrhage and hence the deaths associated with it. So a postpartum kit would basically include certain things beginning with IV cannulas, that is around gauge 16 and 18. That would be the green and the gray one. IV set, IV fluids like normal saline and ringer lactate, syringes of various sizes, 10, 5, and 2 for the administration of drugs, medications, uterotonics like oxytocin, metergin, carbitocin, prostudin, as well as misoprostol. Apart from these medications, it is also very useful to have, if available, a Foley catheter, a condom for tamponade, if available, the use of a Bakri balloon for control of PPH, atonic PPH, as well as the SR PPH cannula or the Panikers PPH cannula. These all help the doctor to control bleeding at the fastest possible rate and hence to prevent further bleeding and maternal mortality that is associated with it. So if these can be kept ready in the labor room to be accessed with at the earliest, and the drug should be routinely checked time to time to see that they are not expired, it would be of great help during the time of delivery. The second topic is episiotomy, which also most of the labor staff would be aware of. It is an incision which is taken in the perineum and the posterior vaginal wall to aid in the aid at the time of delivery. There are various types of episiotomies, midline. Actually, ma'am, without the slides, I think it would be a little difficult for them to understand, but anyways, going on. Midline, we'll just wait for the slides and proceed. Okay, ma'am, if we could go to episiotomy and we'll come back
From
to
which
the,
slide, ma'am?
Ma'am, episiotomy is towards the end, on I think 30, 40, if I'm not mistaken.
Topic of the slide, ma'am?
Episiotomy.
Okay.
Just to advance the slide, the episiotomy is later. The next presentation is episiotomy, not this. This is PPH. You'll have to advance the slides, I think.
Yeah, thank you.
Yeah.
So just recapitulating, episiotomy is a blunt incision in the perineum and the posterior vaginal wall during delivery. It is usually applied during the second stage of labor after the crowning of head to minimize overstretching and rupture of the perineal muscles and to enlarge the vaginal introitus to aid in delivery. It is not necessarily to be done during every delivery. Ma'am, next slide. Next slide, please. Okay. It is not a routine procedure. It doesn't have to be done during every delivery. The indications are if we are anticipating any perineal tear, if the perineum is very inelastic and tight, or we are doing an operative vaginal delivery with the aid of forceps or a vacuum, or if the patient has had any previous perineal surgery, or there is malpresentation like breech or occipital posterior, which requires a bigger space. Next slide. Like I was saying before, there are different types of episiotomy: the midline, lateral, mediolateral, and the J-shaped. Most commonly used is the mediolateral, which may be either on the right or the left. Next slide, please. Next slide. Okay. Care of an episiotomy is important because postpartum, if proper care is not taken of, the patients are quite uncomfortable. They will come with unnecessary infections. So it is very important to counsel the patients for the proper care, as well as for the nurse and staff to be able to detect when there is any problem with the episiotomy. Next slide. So it is always good to educate oneself as well as the patient that healing starts immediately, but it can take up to 3 to 4 weeks to even up to 6 weeks. Drinking plenty of water and having a high fiber diet is important to prevent constipation, because constipation will increase the pain in the episiotomy. Early ambulation and mild exercise also helps in increasing circulation and hence healing. Proper hygiene is very important to be observed. Hence, they should be advised to change sanitary napkins every 2 to 3 hours to prevent infection. And patients should avoid squatting, especially during breastfeeding. Many people adopt this position. This causes stretching of the perineum and hence more tension on the wound. And that could again cause some sutures to fall apart earlier than they were expected to. Next slide. Next slide. Next slide. Management of an episiotomy, usually patients after an episiotomy are normally routinely given antibiotics. Apart from that, they're given painkillers and advice regarding hygiene and advice to have seeds bath, which I will elaborate earlier in the next few slides. Next slide. It's repeating again, but painkillers are not, some people are quite averse to taking painkillers, but they help the pain as well as they reduce inflammation. So it's advised to be taken for at least 5 days to a week post an episiotomy. Placing an ice pack over the perineum also can reduce the swelling and the pain. And a seeds, but very important, post an episiotomy, patients should be advised that doing a seeds bath means, very simply put, we have these seed bath tubs also available, but for those who don't have it, we can always advise them to use a shallow, small tub which can be placed on top of a stool. Place warm water and sit in the water for at least 5 to 10 minutes. If it's possible, 3 to 4 times a day, or at least even 2 times in a day. After that, wipe the area and apply the necessary antiseptic ointment. Doing this for the next 2 or 3 weeks will prevent infections over the episiotomy, as well as aid in wound healing and reduce the pain as well. Next slide. Next slide. Advising the patient certain tips when they go home can also help them in their recovery, like when they first pass urine after delivery and the urine comes in contact with the episiotomy, they can be burning. So pouring warm water over the stitches when passing urine also can relieve the pain. Also, when passing stool, if it hurts in the episiotomy a lot, using either a clean tissue or a fresh pad against the perineum and providing support while passing stool also can ease the discomfort during motions. Keeping the area clean and dry also helps the stitches to heal. And also a small tip here, but whenever getting up and sitting down, the pain is usually most dense. So if they can be advised to tighten the buttocks gently before sitting and getting up, that will also reduce the pain over the stitches. Next slide. Simple exercises. Most patients postpartum are prone to sit on the bed or lie down most of the times and rest, but they should be encouraged to do mild exercises like walking for 10 to 15 minutes if possible, and do the Kegels exercise. Kegels exercise, this needs to be stressed because it's a very simple exercise that they can do even at home in doing normal activities, and this really helps to strengthen the pelvic floor muscles and also reduce urinary incontinence. To simply explain to the patient what is a Kegels exercise, you ask them to imagine them trying to stop from urinating or passing gas at the same time. The muscles that they use to contract at that time is basically what is the Kegels exercise. So they should not do it when they're passing urine, but whenever they remember doing that, day as frequently as they can. To tighten the muscles as just described, count for a few seconds, from 5 to 10 seconds, and then slowly release. Doing that will also help to strengthen the pelvic floor muscles and reduce urinary incontinence in a lot of women post-delivery. Next slide. So in this picture, ma'am, the previous slide. Okay, so I just described what the Kegels exercise was, but in this picture also, the patient lying down on the back with the legs bent, the hands beside. Then the patient has to thrust the pelvis above and then bring it slowly down. Even this motion also is a form of Kegels exercise, and it helps to strengthen the pelvic floor muscles. Next slide. Okay, so what does monitoring of the episiotomy to see if there's any infection looks like? Because the first 7 to 10 days is usually when we know how well the wound is healing. If there is an infection, there will usually be pain in the stitch. The wound may even break open. There may be discharge or pus from the wound or a bad odor. If there is any hard or painful lump in the area, that could be a hematoma, which needs to be addressed to. And if the skin between the vagina and the anus looks redder and swollen than usual, this usually is a flag point for an infection happening in the wound, and hence it needs to be referred to the treating doctor or to be addressed to and looked and treated at the earliest. Next slide. Okay. Complications. Episiotomy also has a share of complications, the most common being infection. Apart from that, there can be bleeding. If an episiotomy doesn't heal well and sometimes develop something called episiotomy granulomas, these can also cause painful intercourse, also called as dyspareunia. Injury to the anal sphincter and the rectum during an episiotomy also can cause incontinence, as previously discussed. An episiotomy in some people, if it doesn't heal well, can cause scarring. Urinary incontinence can also be there apart from anal incontinence, and sometimes an episiotomy can take quite a long time to recover and cause a burden or an inconvenience to the patient. Next slide. Okay, we will now be discussing medical waste and the management. Waste generated from the healthcare facility is classified into biomedical waste, general waste, and other waste. Out of this, biomedical waste consists around 15% of the total waste. This can be further divided into non-infectious, infectious, and hazardous. Next slide. Why biomedical waste is important, and this is something that our state is just waking up to recently, but it is very important because if we do not dispose of the biomedical waste properly, it can cause harm to people, that is ourselves, also health workers, patients, waste collectors. It poses health risk because we are treating a lot of sick people, and improper disposal of this can also cause the spread of infection. There are biological risks. It can cause pulmonary hepatic risk, bioaerosols, chemical risks, hazardous waste risk, like burning garbage in the improper way can also causes a lot of air pollution, and in that terms also again a health risk. Dumping risk, it can contaminate underground water, soil with various coliforms, heavy metal exposure, as well as dumping it in the sewage. This also can cause salt and water contamination and algal blooms. Next slide. Steps involved in the management of biomedical waste. Segregation of waste in color-coded bags at the point of generation. Then intra-departmental transportation of the segregated waste to a common storage area where there is temporary storage of the biomedical waste. And then after that, transportation to the authorized facility. Next slide. Segregation. Segregation basically refers to the separation of different categories of waste generated at the source. This reduces the risk and cost of handling and disposal. Effective segregation alone can ensure effective biomedical waste management. Next slide. So this is a very important slide in which we can see the four here mentioned, the four colors. One is yellow, red, white, and blue. The yellow bag, the yellow color, this is for infected human anatomical waste, animal waste, any soiled waste, or even discarded medications, chemical waste, lab waste, or any liquid chemical waste. The red bag, this also contains contaminated waste, but this is easy to remember. You just say infected plastics. Infected plastics, this and also rubber. Infected plastics would include IV cannulas, tubings, Foley's, urine bags, syringes without the needle, gloves, and even blood transfusion sets. The white bag is usually a puncture and leak-proof container. This is for waste, sharps, including metals. The blue bag is for glassware. That would be the vials for antibiotics and other IV medications are to be disposed of in the blue. So just to review, the yellow bag is for anatomical waste, which can be the waste generated during dressings and even in the OT. The red one, simply to remember, is for plastic and rubber. Next slide. Ma'am, is there some problem?
Monica ma'am, the slide has...
Bolo. Saiti is there.
No, the slide is not visible, ma'am.
Okay.
One second, ma'am. Give me a second.
Yeah, just a minute. करेगी वापस हाँ.
Okay, thank you. Next slide, please. Next slide. Okay, so as previously discussed, we first segregate the waste. Then after that, the segregated waste is temporarily stored before they are transported to the common regional facility for their final disposal. Next slide. While handling and disposing of these biomedical waste, the staff who are handling this should always use an appropriate PPE, personal protective equipment, which involves using a mask, a face shield if possible, and gloves and a gown. The labeling of biomedical waste, this, as you can see in the screen, the first is the biohazard symbol. And if handling cytotoxic hazard symbol, the one with a black triangle with a C. This label should be non-washable and prominently visible so that people who are handling would know and take necessary precautions. Next slide. So just to summarize, proper disposal of the waste, segregation of the waste, after which there is handling and temporary storage, after which waste is transported and disposed of in the proper manner. Next slide. So the disposed of biomedical waste is then finally disposed of in the various ways, as we can see. One is by autoclaving. Basically, that is like steam sterilization, microwave, incineration, pyrolysis. Pyrolysis is basically destroying materials at temperatures, at high temperatures without oxygen, and a sharp spit. Sharps are usually disposed of in a deep pit so that it doesn't come in contact with others and cause harm in the other way. Next slide. So there are certain do's or don'ts when handling biomedical waste. The first and foremost is prior segregation of waste, which is a must. Secondly, all healthcare workers as well as people who are taking part in the waste management should be vaccinated against hepatitis B. Wear heavy-duty gloves while handling infectious waste. Do not allow the bags and the containers to overfill. Always see that there are at least no further waste is collected beyond 3/4 of the bag. The waste bag should not be hanging at the edge. And do not transport the waste by dragging the bags. It can cause tears and spillage. Next slide. Like mentioned before, biohazard bags should not be overfilled. They should fill up only up to 3/4 the level. If there are any spills during transportation, it should be treated with the appropriate disinfectant. Do not recap needles. Needles should be destroyed with heat if available, or in the sharps bin after the needle is destroyed. And do not throw needles in biohazard bags or non-puncture proof vessels because it can cause harm to those who are managing the waste. Next slide. Okay, that would summarize the biomedical waste. The next topic we are going to discuss today is eclampsia. Eclampsia is a medical condition due to high blood pressure, due to preeclampsia, where the pregnant patient presents with tonic-clonic seizures or can go into coma. But a little more beyond that is this can occur even in a postpartum patient and not only in a pregnant patient. So after delivery, it is not impossible for a patient to come with eclampsia. It is a life-threatening condition if not attended in an emergency. Next slide. So basically, an eclampsia tree that I will be enumerating is a set of medications and instruments that we need in the time of eclampsia, which, if kept ready, can help management of the patient at the fastest and quickest possible manner. The first thing when a patient comes with eclampsia is you call for help. We assess the airway, breathing, and circulation. Next slide. Place the patient in a left lateral position. If at all the patient is big and very unruly and unable, at least turn the patient's head to the left side before someone else can come and help you. This will improve, this would prevent aspiration. And at the same time, turning the patient to the left lateral position will improve the venous return and hence, as mentioned, decrease the risk for aspiration as well. Next slide. Next slide. After the patient is kept in the left lateral position, usually an eclamptic patient, froth in the mouth, they have tongue bites and they have a lot of secretions, which once they come into consciousness, they could aspirate with it. So quickly do a suction as available and put an airway so to prevent the tongue from falling back and causing further obstruction of the airway, as well as to prevent tongue bite. Next slide. So in an eclamptic patient, some of the tools needed and that can be kept ready is a blood pressure cuff, a pulse oximetry, a stethoscope, a thermometer, a Foley's catheter, and neurological assessment tools like the Glasgow Coma scale. Next slide. Medications that are needed in management of an eclamptic patient, the first and foremost is magnesium sulfate, which I will be elaborating on a little bit further in the next slides. Injection phenytoin, injection diazepam, oxytocin, carbetocin, posidone, labetalol. These all come in the further management of eclamptic patient, which may not be immediately, but in case the patient is about to deliver or undergo a cesarean or comes with bleeding. Next slide. Magnesium sulfate, as just previously mentioned, there are different regimes used in an eclamptic patient. The most commonly used in India is the Pritchard regime. In this, we have a loading dose of 4 grams IV. This is a 20% solution and followed by 5 gram IM, 50% weight by volume solution in each buttock. Maintenance dose is 5 gram IM in alternate buttocks every 4 hours for 24 hours after the last convulsion or after delivery, whichever occurs later. Next slide. So this magnesium sulfate, it comes in an ampule of 2 ml and the ampule will be written 50% weight by volume. So that comes out to be, there is 0.5 gram in 1 ml. So in a 2 ml, that is basically in 1 ampule of magnesium sulfate, there will be 1 gram of magnesium sulfate. So when we have to give it IV, it's supposed to be given at 20%, not at 50. So we take a 20 cc syringe in which we take 4 grams of magnesium sulfate, which would come up to 8 ml. Then the rest we dilute it with normal saline or with 5% dextrose. Hence the total amount will come out in a 20 cc syringe and it is pushed slow over 5 to 10 minutes, following which the loading dose in the buttocks, that is 5 gram, is given on each buttock and the time has to be charted because the further dosing is done based on this first loading dose. Next slide. Before I go into labetalol, a little bit about the magnesium sulfate. Magnesium sulfate has its share of side effects and hence monitoring is very important. Though it's not mentioned in the slide, there are certain parameters that need to be monitored while administering magnesium sulfate. One is the deep tendon reflexes, or also called the patellar reflex. If the patellar reflex is absent, no further dose should be given. The doctor should be improved and necessary decisions should be taken. The next is respiratory rate. If the respiratory rate is less than 12 per minute or the urine output is less than 30 ml per hour, these 3 conditions, magnesium sulfate should not be, further doses should not be given unless there is a reassessment and then according to the requirement, the next doses should be determined. But as far as these 3 parameters are there, further doses of magnesium sulfate should not be given. Injection labetalol. This is the most commonly used IV antihypertensive that is used in an eclamptic patient, because they are usually in an altered sensorium, they cannot respond, and hence we cannot administer any oral medications. Injection labetalol initially should be given at 20 mg IV, slow over 2 minutes. Wait for 10 minutes, repeat a BP. If there is no response, double the amount, that is 20 mg, give IV slow, again wait and see if there's any response. If there is adequate response, further dose may not be required. If not, the dose can be again doubled every 10 minutes. The target is to reduce diastolic blood pressure to 90 to 100. The maximum dose of labetalol usually is 300 milligrams at a time when given IV. Next slide. During management of an eclamptic patient, as we discussed before, apart from securing the airway, large bore IV line should be secured. Oxygen mask with supply of oxygen should be connected. As far as possible, cardiac monitor should be applied, as well as seizure pads and pillows if available, because an eclamptic patient can get very violent and can self-harm as well as harm healthcare workers as well. Next slide. Just elaborating on what I said before, the bed rails of the patient should be secured. Comfortable blankets or pillows should be given. Eye protection for seizure prevention. An eclamptic patient should be kept in a quiet room, not where there is a lot of people going up and down and a lot of noise, because even the noise and the loud sounds can trigger another eclamptic seizure. Next slide. Just to summarize, when preparing the eclampsia kit, we should label each item clearly, organize items such that it is easily accessible, store the kit in an easy to access location, and as mentioned previously for PPH as well as for eclampsia kit, always check the expiration date of the medicine and supplies and restock the kit as needed. Next slide. Next slide, please. Next slide, please.
I think Satabdi ma'am. Okay.
Okay. The next topic will be postpartum care or postnatal care. Basically, the postpartum period is the 42 days post-delivery. And the objective of this is to describe what composes of postnatal care, the number and the timing of postpartum visits for the mother and the baby, what activities, what needs to be assessed during each visit, and when to refer the mother and the baby to a higher center, and to counsel and motivate the mother to adopt contraception. Next slide. So just recapping, the first 6 weeks, that is 42 days after a delivery is called the postpartum period. The first 48 hours is very important, the most crucial period. And even though it may seem like after delivery, everything is over, more than 60% of maternal deaths takes place during the postpartum period. And hence, it is also very important to monitor this period. Next slide. Okay. Postpartum visit by the ANM or the ASHA worker. This may not be applicable in all scenarios, but whenever applicable, the first visit, if the patient is delivered at home or at a sub-center, should be within the first 24 hours. The second visit on the third day, that is same as for those who are discharged after delivery from a PHC or a first referral unit. The third visit on the 7th day, and the fourth visit after 6 weeks. That is once they complete the postpartum period. Next slide. So during the first postpartum visit, the things to be seen in the mother as well as the newborn, I will just elaborate. History and examination. History, as in if the mother is having any complaints, anything that is troubling her, any problems that she's facing, that you would be able to understand and guide her accordingly. Examination, we will elaborate a little bit further on examination in the further slides. Management and counseling, this would include, we will be elaborating the further slides, but just as a summary, postpartum care and hygiene, nutritional advice, the need for rest, iron, folic acid, and calcium supplementation, contraception, breastfeeding, and to advise regarding birth registration. Regarding the newborn, since history will be given by the mother, examination, newborn care advice regarding newborn care, how the baby should be kept warm, keeping the baby clean, especially the cord, regarding breastfeeding and immunization. Next slide. So postpartum care and hygiene. This involves advising the patients regarding how they need to keep themselves clean to prevent infections, washing the perineum daily and after passing urine and stool, to change pads every 4 to 5 hours. Patients should be encouraged to take bath daily as far as it's possible. The need for rest and sleep. And also she must keep the baby with her. There's something called rooming in. This helps bonding and also helps her to be alert whenever something goes wrong with the baby, and not keep the baby separate and the mother separate. Also, the mother should be advised to wash hands always before touching the baby. Also, to prevent pain as well as episiotomy dehiscence, they are advised to abstain at least 6 weeks from intercourse. And as previously mentioned again, rooming in with the baby is very important. Next slide. Nutritional advice. On discharge from the hospital, patients always ask what they can eat, what they cannot eat. It is always good to advise patients that they should have a good amount of fluids, lots of green vegetables, fruits, eggs, and meat as well. Many people avoid meat thinking that it causes wounds to get infected and septic, and hence they go only on a boiled diet till the wound is healed. But protein is very important for wound healing, and hence that needs to be stressed in a lot of people, especially on this side. Patients should also be encouraged to take milk and milk products, curd, cheese, because these are rich in calcium. Apart from these, our diet has very less amount of calcium, and hence the need to stress this as well. We are repeating a few things again, but yes, adequate rest needs to be stressed, as well as the importance of iron, folic acid supplementation, as well as calcium and contraception. This cannot be stressed enough, because most people generally avoid any talks with regarding to contraception, and they are not very receptive whereas it comes to contraception. So sensitizing people regarding the various methods available and that can be used during the breastfeeding period also can help them plan their future pregnancies such that accidental pregnancies do not take place. Counsel the mother for certain dangerous signs, which we will discuss again. Correct positioning of breastfeeding and care of the breast and the nipples. Exclusive breastfeeding for at least 6 months. The diet we have already mentioned, and the hygiene and the contraceptive we have already mentioned before. Regarding the newborn, we are repeating a few points, but advise patients not to bathe on the first day, so that the baby, usually they end up having hypothermia. So to prevent that, also to keep the cord stump clean and dry, and not to apply any medications or honey or any other thing to be applied on the stump. And also additional checkups and follow-up should be done for the low birth weight babies, that is less than 2.5 kg. Routine immunization should be explained and advised so that the mother can follow up accordingly. Danger signs in the baby will be discussed in the following slides. Next slide. breastfeeding. Exclusive breastfeeding for the first 6 months should be encouraged to all mothers. Breastfeeding on demand, that would come to at least 6 to 8 times or even 10 times in a day. The mother should avoid pre-lacteal feeds. Pre-lacteal feeds means giving the baby either water or sugar cane juice or honey, as in some customs they practice. These should be prevented because breast milk is sufficient during the first 6 months of life, and no other additional feeds are necessary, even though a lot of old wives' tales come up and they say that the baby is feeling thirsty and they need this and that. It should be avoided because these are the ones that cause infection to a newborn. Breast engorgement is a common complaint that happens when a mother is first starting to feed. They should be encouraged to breastfeed, and if it is too painful and the baby is unable to feed, they can always do warm compression and slowly express the milk out or use breast pumps as available. Another problem is cracked nipples. This can happen to anybody, but mostly if the position, the latching is not correct, it tends to happen even more. So first and foremost, the proper positioning of the baby while breastfeeding is very important. It may take some time, but the mother should be explained about the proper position. As we can see in the picture, the baby's mouth should be wide open. The chin should be almost touching the breast, and the nose should also be touching the breast, and the lower lip should be turned outward. Proper positioning would ease the breastfeeding as well as prevent further cracked nipples and sores. When there is cracked nipple and sores, although there are ointments to be applied to such, the most simplest treatment is to apply hind milk. Hind milk is basically the milk that comes out after the baby finishes feeding. That is a little oily, so the mother can express a little milk after the baby is done feeding and apply it over the nipples, let it dry, and repeat this process. This helps in healing of the cracked nipples. Next slide. Danger signs. When there are these danger signs, the woman should be counseled to report to the hospital immediately. Or not only the woman, but even the relative should be explained regarding these. Fever, convulsion, if there's excessive bleeding, severe abdominal pain, difficulty in breathing, or there's foul smelling discharge. Next slide. Even in a newborn, there are certain signs that are danger signs in which the mother or the relative should take the baby as soon as possible to the hospital. That is cry inactivity. If there is a very poor cry, the baby is very lethargic, not moving, not reacting, or unconscious. If there is chest indrawing, this is a sign of pneumonia. If the respiration is less than 30 breaths per minute or more than or equal to 60 breaths per minute, if there's central cyanosis, that is bluish discoloration of the tongue and lips, if the temperature of the baby is less, that is less than 35.5 hypothermia, or if it is more than 37.4. If the umbilical stump is bleeding, there is redness or pus, or if there is any skin infection that is more than 10 pustules or a big boil. Jaundice. Jaundice is a very commonly seen in newborns, but if it appears within the first 24 hours of birth, this is a red flag. This needs to be addressed immediately. And the eyes, if there's any redness, discharge, or swelling of the eyes, or any congenital malformation present if it was missed during a hospital delivery or at home delivery. In such cases, the baby should be transferred and referred to a higher center. This is usually in the case of PHCs or sub-centers. Explain the reason for transferring, fill up a referral form. If possible, contact the health facility in advance. keep the baby in skin-to-skin contact with mother. This is quite important, just like something like kangaroo mother care, because the skin-to-skin contact with the mother keeps the baby warm and it helps the baby recover much faster. If not possible, keep the baby dressed and covered. Ensure that the baby receives feeds if the baby is accepting feeds in the first place. If the baby is gasping or the respiratory rate is less than 30 or the heart rate is less than 100, baby needs immediate resuscitation and the necessary doctor, if available, should be informed at the earliest. Next slide. Actually, this is the last slide, but we have not discussed one topic, the universal precautions. I think that is at the beginning of the slide because we started in between. So, ma'am, if we could go to the first slide, I will just briefly discuss the universal precautions. Yeah, thank you. This is the last topic that I'll be talking about, universal precautions. These are control guidelines designed to protect health workers from exposure to diseases spread by blood and other body fluids. It is an approach to infection control to treat all human blood and certain human body fluids as if they were known to be infectious for HIV, hepatitis B, or other bloodborne pathogens. The concept of universal health precaution emphasizes that all our patients should be treated as though they have some potential bloodborne infection and can infect the caring healthcare workers. Next slide. When treating patients in a hospital, we don't know who is infected. So while handling these tissue materials, we need to be extra cautious, like blood, semen, vaginal secretion, cerebrospinal fluid, synovial fluid, amniotic fluid, or any other body fluid. Next slide. The other body fluids mentioned here, like sweat, tears, these are not necessarily infectious, but sputum, vomitus, saliva, these also can cause infections that can spread to one another. So any bodily secretion, for safety's sake, should be treated as infections, and necessary precautions should always be taken while handling any of these secretions. Next slide. A lack of universal precaution can be a potential hazard to employees working in a hospital or a healthcare center. Employee exposure to bloodborne pathogens from blood or other potentially infectious material like those mentioned before, because employees are not using universal precautions. Bloodborne pathogens are pathogenic microorganisms that are present in human blood and can cause disease in humans. Most of you will be aware, but just to elaborate, the most common being HIV, hepatitis A, B, C, but there are others like which cause gastroenteritis like salmonella, shigella, tuberculosis, which is very common, a lot of urinary tract infections, chickenpox and measles as well. But like stressed above, HIV and hepatitis are the most common and the greatest of risk among all these. Next slide. Bloodborne pathogen standard requires employees to observe universal precautions to prevent contact with blood or other potentially infectious materials. Under circumstances in which differentiation between body fluid types is difficult or not possible, all body fluids shall be considered potentially infectious material and hence treated as so. Treat all blood and other potentially infectious material with appropriate precautions like wearing gown, mask, or a face shield, and as well as good engineering and work practice controls can also limit exposure. Next slide. Now, the breakdown of what is actually comprises of the universal precautions, what it consists of. First and foremost is hand hygiene, which all these topics, that are elaborated here, we'll be discussing a little bit in detail in the next slides. Hand hygiene, gloves, facial protection, gown, prevention of needle stick injuries or injuries from sharp instruments, respiratory hygiene and cough etiquette, environmental cleaning, linen, waste disposal, patient care equipment. Next slide. Hand hygiene. This has been stressed a lot during the COVID epidemic, and hence I think a lot of us are aware about it, but hand hygiene cannot be overemphasized. Hand washing, this should not be just a few seconds wash and you think that you have washed hands. It should be at least for 40 to 60 seconds. Hands should be wet, apply soap, all surfaces should be scrubbed and cleaned properly. There are many steps of hand washing that it started with 6 steps and now there are almost up to 10 steps of hand washing, but the bottom line is that all surfaces of the hands should be cleaned. After washing hands, hands should be thoroughly dried with a single-use towel, and the faucet, the tap should be turned off with the same towel so that there is no contact with the tap as well. When hand washing is not possible, using a hand sanitizer also is equally efficacious, but see that it is used properly. The hand sanitizer should be used to use enough, like you should take enough of hand sanitizer, rub it all over the hand to cover all areas of the hands and rub till it is dry. Next slide. When should hand hygiene be practiced? Even if all may be aware, just stressing on some points. Before and after any direct patient contact and between patients, whether or not gloves are worn. Immediately after gloves are removed, before handling an invasive device, after touching blood, body fluids, secretions, excretions, non-intact skin, and contaminated items, even if gloves are worn. During patient care, like when moving from a contaminated to a clean body side of the patient. After contact with inanimate objects in the vicinity of the patient. Next slide. Gloves. Using gloves is important when touching blood, body fluids, secretions, the mucous membranes, or non-intact skin. We should always change gloves before tasks and procedures on the same patient after contact with potentially infectious material. Most often, after doing dressing on one part, in the hurry, the same glove is used and it is used to touch another part of the same patient. These can cause infection even on the patient itself, so this should not be done. Remove after use, before touching non-contaminated items and services, and before going to another patient. Very, very important. Even in a hurry, also always remember to remove your gloves before going to see another patient or to pick up the patient files. Perform hand hygiene immediately after removal. Next slide. Facial protection. This can involve using doing surgeries or doing any procedures on patients where you are expecting some splashes, like doing deliveries. We can either use eye goggles or use a face shield which can protect the eyes and nose and the mouth to prevent from blood splashes or bodily secretions and excretions. Next slide. A gown. It is worn to protect the skin and prevent soiling of clothing during activities that are likely to generate splashes, sprays of blood, body fluids, secretions, or excretions, as previously discussed. As soon as the procedure is done, the soiled gown should be removed and disposed of accordingly, and perform hand hygiene. Next slide. Prevention of needle stick and injuries from other sharp instruments. Extra care should be used while handling needles, scalpels, and other sharp instruments or devices, or cleaning used instruments. Disposing of needles which are used or other sharp instruments should be done carefully. Respiratory hygiene and cough etiquette. Since the flu is quite common, recently also we've had quite a lot of patients having the flu. This is quite important. It's a small measure, it may seem like, but patients as well as we ourselves should practice this and explaining to the patient as well. People who have respiratory symptoms should cover their nose and mouth while sneezing or coughing with either a tissue or use a mask, and dispose of the tissue and mask appropriately. Perform hand hygiene after contact with respiratory secretions. Healthcare facilities, as far as it's possible, even though it may not be possible everywhere, patients who have acute febrile symptomatic respiratory problems should be placed at least 3 feet or 1 meter away from others in common waiting areas. Visual alerts at the entrance to healthcare facilities instructing persons with respiratory symptoms to practice respiratory hygiene or the cough etiquette are useful in creating awareness. Also, it would be good if healthcare facilities make hand hygiene resources available, tissue and mask in common areas used for the evaluation of patients with respiratory illnesses. Next slide. After all that we have discussed, the appropriate waste disposal, we have discussed the biomedical waste, but even the waste generated when we are practicing the universal precautions, after using the mask, the gloves, the gowns, it should be disposed of in the proper way as we have discussed earlier. Treat waste contaminated with blood, body fluids, secretions as clinical waste. Human tissues and lab waste that is directly associated with specimen processing should also be treated as clinical waste. Discard single-use items properly. Next slide. Patient care equipment. Handle equipment soiled with blood, body fluids, secretions in a manner that prevents skin and mucous membrane exposure, contamination of clothing, and transfer of pathogens to other patients or their environment. And with regard to reusable equipment, clean and disinfect all such equipment appropriately before using on another patient to prevent infection. Next slide. Okay, I think we are done with the topics that were supposed to be discussed. Thank you very much.
Thank you, ma'am. It was a very lucid presentation, and I hope everybody has understood the key concepts that need to be taken home. Can we move ahead with the
Yes,
next talk?
I think Sunil sir is little bit busy with the OT, but he is asked like he'll be joining in 5 minutes, ma'am.
Okay, so if there are any questions, ma'am, we can take from the audience. So they can put it in the chat box and ma'am can answer them. In the meantime, Kevin sir, your comments about the lecture, we can take, ma'am, sir.
It was an excellent presentation. Thank you, Dr. Apili, for such a well thought out, meticulous addition. And it's so good for all the health workers, especially doctors, also nurses, also. And one thing I would like to just elaborate, or maybe not elaborate exactly, but just ask Apili also, or to ask her opinion also. Previously, episiotomy, we usually use catgut all the time. But
Yes.
nowadays, of course, Vicryl is costly, but I have shifted to use of Vicryl for the reaction and even faster healing also. So what is your opinion on this, Dr. Apili?
Yes, sir. I also agree that Vicryl has better wound healing.
Mm-hmm.
It's just expenses wise. So if like we working in a private setup, if it is possible for the patients, rapid Vicryl would be a better option over comic catgut. But if the patients are not affording, then yes, we need to make concessions and do accordingly. Yeah.
Oh, okay. Thank you so much. Any other question from the delegates or anything we can just discuss? Any other from the faculties also can ask. Thank you so much, Apili.
Thank you.
Yeah, ma'am. Like I have one question, ma'am. Like during the episiotomy wound repairing, do you have any experience regarding the subcuticular repair compared to the mattress? What is the difference?
Uh, Ma'am, I would say it depends on the situation because if the episiotomy is a small one,
Yes, ma'am.
and maybe in a primary, I would say, because in multi, if the tissue is very loose, it may not be so, it may not hold up so well. But if the episiotomy is small, subcuticular also works in some patients, but it depends on patients because if the patient is compliant, you know that they would be able to follow up, they'll be able to maintain hygiene, then a subcuticular can also work. But if the patient is quite big and if at all they are, they are not very cooperative, we understand patients by the way we see them. So
Yes.
I think it should be decided based on case to case. Yeah.
Yeah, obese and those who are prone to infection and those who
Infections, yes.
seem to be lost to chances that they won't come for the follow up. It's better
Follow
we
up,
give
yeah.
because in subcuticular we'll need a proper care and hygiene practice. Yes, ma'am. I think Sunil sir. So we can
Okay.
take question from the participants or delegates if anyone has
Yeah,
to.
they can put them in the chat box or unmute and ask ma'am. But can you please call ma'am because ma'am, we will have to finish this program by around 6:30. So sir has to start the presentation. Are there any questions from the audience? You can also share your feedback about the program in the chat box so that we can improve on the later next programs.
Sir is caught up in CS. I think he'll be joining in another 2 minutes, ma'am.
Okay, ma'am.
Yes, ma'am.
We'll wait for 2 minutes for sir to join and then we can start directly, ma'am.
Okay, ma'am.
Yeah.
And in meantime, if any delegates or participant has question, they can put up in the chat box.
Hello, everyone.
Yes, sir.
So sorry, Sunil is caught up in an emergency operation and he's about to wind up. Just give him 1 minute or so.
No, no problem, sir. We'll wait. We'll wait for sir to join and then we'll finish the talk. So, sir.
Yes, yes. By the way, thank you so much for taking the initiative to start a CME like this. It's so helpful for each and everyone.
Yeah, it is important to reach the staff nurses, sir. That is more important. That is why we generally give the delegate link as well as the faculty link. So if you cannot join with this, join with the other types.
Yes, thank you, ma'am. Thank you, ma'am.
Yes, thank you. In the meantime, Shatabdi, if you have any questions that you think that the staff nurse needs, we can ask ma'am, both the madams to answer them by the time sir joins.
Yes.
Yeah.
Nothing that I can see in the chat box. Madam has explained in detail, actually. Kevin, sir, anything that you want to stress on since we have a minute, especially for the staff nurses?
Okay, thank you. Well, we were discussing about that question being asked about episiotomy with subcuticular stitch and all, no? So those are basically, of course, some people are very cosmetically aware also, but at the same time, uh, we should be careful in in management of the post-operative care, because like subcuticular sometimes can land up in unnecessary hematoma, and the best stitch is usually the interrupted sutures only. So, excuse me, interrupted sutures, the minor bleedings in and around also can get proper hemostasis. So, subcuticular, if you feel that if it is
That
perfectly
rightly said, sir. That area is also vascular, no, especially
yes,
during the
exactly, exactly.
that area is vascular also. So
Mm.
very, very rightly said, subcuticular can land up in some unnecessary hematomas and unnecessary morbidity. So,
That's
sir,
right.
yeah, so that very, very rightly said. Very, very rightly said. Sir, one more thing that we since we have been doing this quite often now, uh, I was attending this conference where there was a detailed workshop on using the PPH cannulae. So they are very, very helpful, sir. At your level, also, if you can encourage using them, or if you use them or encourage your staff, it can be managed by a staff nurse. It can be, mane, at the baseline level, at a very peripheral place, also, it really helps in controlling the PPH.
Oh,
So,
yes.
so then PPH cannula also is one thing that probably you can stress, and it can be managed by the staff nurses also. We need not
Mm.
be a doctor to manage it. So then that also is one thing that probably we should be stressing more to the staff nurses.
Exactly, exactly, ma'am. That's
Yes,
a very
yes,
insightful thing. And another thing
yes.
which I want to stress to each and every nurse or doctors is, well, we have done the cesarean section, the surgery very correctly to our satisfaction. There's complete hemostasis, But the next 24 hours, the monitoring part in basics, the BP, the pulse rate, then the urine output, those things, sometimes the patient may have a slight elevation for a time, a slight elevation of pulse rate, but if it is persistently, pulse rate is hovering around 100 plus all the time, then naturally there may be not bleeding also, but patient may, after an operation, the patient may even be going into a little bit of anemic or maybe fluid overload and all these things. So these things have to be properly monitored and get alarmed, get help at the earliest, Otherwise, we say it's always normal, normal. Ultimately, the SpO2 falls down, the pulse rate is racing high, the BP is falling down. Then, as a doctor, all of a sudden we come across this. The only things that strikes our mind is, probably there is a bleeding inside, there is a hemorrhage inside, kind of thing. So slow and meticulous monitoring of postpartum patient, especially even cesarean or maybe even a normal delivery, it is a very important thing, actually. Thank
Pulse rate has to be given importance. We don't tend to give it as much importance as it deserves. Pulse rate, abdominal girth. During our residency days, our VS was very, very particular about the abdominal girth. Like we had to keep it a hourly monitoring of abdominal girth and pulse rate.
you.
So I
Yes.
think we don't tend to give it so much importance, but it can give us a lot of information.
Yes, ma'am. Yes, ma'am. Exactly.
Sunil sir has joined, I think. Sunil sir, are you there?
No, I
Sunilji,
cannot still see him.
Yeah. Sir is about to join. He has just clicked on the
Yeah.
link, so he is joining, ma'am.
Okay. Okay. Okay.
okay.
Very low.
what is the rate of normal deliveries and all at your place, sir? How is it over there? Has it decreased over a period of time, or is it just curious?
Oh, okay, ma'am. Usually, there is a slight difference in government setup and private hospitals. Private hospitals have a higher percentage, like around 30 to 40% CS rate, whereas
Mm.
government hospitals are still at the rate of below 30 kind of thing. So that could be attributable to increased monitoring also. At the same
Mm.
time, patients, uh, the nutrition level, at the same
Mm.
time, patients exercise,
True.
lifestyle, and all these things proper.
What about the choice, sir? Are you getting patients who choose to go undergo an elective cesarean?
Definitely, choice, cesarean by choice. And
Mm.
usually, private practice, we usually get elderly more frequently also.
Mm. True, true.
So that way, they are more aware about it also. Then they don't want to undergo the pain and all these sorts.
Mm. Mm.
You go for cesarean section by choice, also is theirs.
Mm.
It tends to be a bit higher.
It's
And the lifestyle issue is also there, where
definitely, definitely, sir. We over here, I practice in Shiliguri. I basically practice infertility. I do get quite a bit of patients from the northeast for fertility procedures. I think they tend
oh,
to conceive at a higher age, as you said, elderly ones. So
yes,
yes, yes. So probably that is one thing that I've noticed. No, we get quite a bit of patients from the northeast who have come for fertility treatment. No, quite a bit, quite a
great,
bit.
great, great, ma'am.
Ah, so,
What I've
so
been noticing is the
ah,
Northeast, basically maybe a lifestyle issue also, but genetically also,
mm,
by even around 35, 40 also, it's still fertility is still there.
yeah,
But among the
yes.
mainlands, what I have seen is
Mm.
by 35, the AMH becomes too low, something
True,
which I have noticed.
true.
So
Very true, sir. Very, very true. I was just about to say that. I get patients in their mid 30s with very low AMH.
that's what,
And
ma'am.
and and
Also,
some of these who opt for a third party, so searching a egg donor for them is difficult because of the
fine.
physical appearance. It does not match always. No, it has to
Exactly.
match also. So then that is one
Okay.
thing that we face quite a bit over here, and it is low. Sir, overall also I think the AMH, man, the fertility is on the lower side. Man, people are having low AMHs at low ages. Man, at in mid 30s, we see that over
And that
here
is
also.
more common with medicos also. Stress is a
Yes.
very,
Very
very important.
excellent.
Medicos have all the issues in the world. All the medicos pregnancies are complicated. Everything
Mhm.
happens with medicos somehow.
Yeah.
See, you
I
might
think
not have heard very few medicos who have had uneventful pregnancies. Almost all of us have had some or the other thing.
Some weird anyway.
Yeah, true, true. That is
Yes,
true.
okay.
yes,
I
ma'am.
think Sharma sir has now
Yeah,
joined,
Sunil sir
so
has
Oh,
joined.
that's
we can
great.
start.
Great.
Yeah.
Yeah, welcome,
Welcome,
sir.
Sunil.
Welcome, sir. Yeah, we
Yeah,
were
yeah.
just
Thank you.
discussing joined. Yes, welcome, sir.
Thank you.
Yeah. So you will be sharing the slides from your end, or you want the technical team to start?
Yeah, I want them to start. The
Yes.
Yeah.
technical team to
Saiti,
start.
can you please start the first presentation? Hello?
Yes, ma'am.
Yes, ma'am, I
Yeah.
will share in a minute.
Yes, yes. Thank you. So in the meantime, you can start speaking. She'll share it from her end.
Yes, ma'am. Kindly let me do that.
Okay, so ma'am, should I introduce sir? I
It's
think.
okay,
You
ma'am.
can,
I'm
ma'am.
Yeah.
consultant gynecologist working in the Nikos Hospital, Dimapur, Nagaland. And
Okay, thank
sorry
you.
for the delay and sorry for the inconvenience. And without delay, I would like to start my topic. And today, as we know that we are discussing about a very crucial topic, and that is about the communication skills to build up and respectful maternity care and empowering the nursing staffs and transforming the outcome. That is our topic for today. So as we all know that this is a very important topic. And why does this matters? Okay, next slide. Why does this matter? Because you see that the state of maternity care in India today, where we can see that 45% of the women have reported disrespect during the process of delivery, undergoing delivery in hospital or in the government setups. And we are having the maximum number of annual birth rate, which is 29 million. And one in three ladies, they are avoiding the medical health facility because of having reported negligence or some sort of verbal abuse or some other traumatic experience in the hospital settings, because of which they are avoiding to come to the hospitals. And or they may have experienced this type of thing by personally or through other people who must have reported. That's why at least one in three ladies are avoiding the health facilities. And this is a big number when it comes to the overall. So this has to be, we have to work on this segment so that we can increase the turnover. Okay, thank you. Next slide. So what is the respectful maternity care? Here we can see that it is a globally recognized framework ensuring that every woman achieves care that upholds the human rights, dignity, and autonomy throughout pregnancy. And here we can see that the different uh, part of this respectful maternity care, it involves human rights, cultural sensitivity, and freedom from abuse, emotional support, equitable treatment, informed consent, dignity, and privacy. This is the things that we are going to talk about in our respective slides. Next. So the seven rights of women during childbirth. That is right to dignity. That is every woman must be allowed, should be treated with respect and regardless of the caste, class, or background. Second is the right to information, which means that clear, honest explanation of all the procedures, options, and outcomes should be given to the patient. Right to informed consent, no procedure without explicit, voluntary, and informed agreement should be done. Then right to privacy and confidentiality, that is we have to ensure the patient's privacy during examination and delivery. Right to companionship, that is they can choose a companion whomever they feel comfortable with while they're undergoing the delivery. Freedom from abuse, that is there has to be zero tolerance for physical, verbal, or emotional mistreatment of any kind. And right to equitable care. So these are the seven segments that we have to uh, we are going to talk about. Next slide. So recognize disrespectful and abuse. Recognizing disrespect and abuse. So abuse can be in any form. It can be verbal abuse, like shouting, shaming the patient, coercion, like pressurizing women to accept some procedures, like if she is has very apprehension about episiotomy and or oxytocin augmentation, and without her consent, we are increasing the oxytocin dose or letting her undergoing extensive episiotomy, or if we just neglect the patient, leaving the patient unattended, even if she's calling for help, if you don't respond, or breach of privacy, and especially like the social media where we are setting informations, so or open curtains and discussing some important issues with the patient publicly, or allowing unauthorized person in the delivery room. So all these things we have to recognize. Next slide. So at the center of all these things, that we are, nurse is at the center of the change, and that is very true because all the time we are not able to stay with the patient. So it is our duty to educate the nurse and give her the charge of taking all these important decisions. So doctor may make clinical decision, but nurse are the continuous constant presence besides every woman throughout every hour of labor. So the proximity is that this proximity is the main power. So she can be the emotional anchor, because she can repeatedly reassure the patient, have eye contact with the patient, and the calm presence reduce anxiety and improve birth outcome. This is evidence-based care. Second is the, I think I'm audible.
Yes, sir, you're audible.
Okay, ma'am. Thank you, ma'am. Rights protector. So the nurse is the first line of defense where the women's rights are at risk, whether from a colleague, a protocol, or a systemic failure. And voice and advocate. Nurse who speaks up for the patient with confidence and evidence. She shapes the word culture, one interaction at a time. So it becomes very more important that we educate our staffs. Next, practical skills for respectful care. So here we can see that practical skills dealing with high respect, low respect. There is a parameter that is showing us towards and low patient safety and high patient safety. Through this chart, we can understand that
Recording in
this,
progress.
yes, ma'am, like communicate clearly in simple language and introduce yourself. So when the nurse, whenever you are meeting the patient, so just communicate clearly in whichever language that they can understand, and in simple language, don't use complicated words, and just introduce yourself. I am so and so nurse. You can also tell your name so that you have a good rapport with the patient. And secondly, listen actively. You should have eye contact. Don't interrupt the patient. If they are speaking something, give them the freedom to express themselves. And obtain informed consent, explain, ask, and confirm. And then provide cultural support. So if they have some belief according to their customs, then it is our duty that we have to respect those cultural beliefs. So these are not soft skills. They are clinical competencies that directly affect patient safety, satisfaction, and outcome as well. So quick checklist before every procedure we can undergo. Introduce yourself by name, role before touching the patient. Like what is your name, what is your role, what are you going to help the patient in what ways. So explain what you will do and why in the simple language. Like you are going to start the drip, you will give some injection for augmentation of labor, whatever procedure. Just later explain yourself to the patient. Ask permission in simple words like, is it okay if I examine you now? So that builds up the more trust with the patient. Ensure privacy, check in afterwards, like how are you feeling? So these things can be done. So next slide. Navigating barriers, workload, hierarchy, and systemic challenges. So here as we can see, we acknowledge the reality that there is understaffed wards, demanding seniors, and relentless pressure which make RMC feel impossible. But barriers can be navigated. Like if we see that there's high workload, so what's the solution? It's like micro moments of respect. A name used, a curtain drawn, a 30-second explanation, and it doesn't require much time to but it transforms the experience with the patient. Then if we have hierarchical pressure, suppose there are some doctors who are very demanding, so in that time what you can do, you can use assertive, non-confrontational language, like, doctor, the patient hasn't been informed yet. May I explain the procedure to her first? So in this way, definitely the doctor is going to also tell you, yes, yes, you can do that. Or it's okay, let me explain. So that's also a way how we can overcome those sort of pressure. Institutional culture. In these circumstances, we can like do documenting the RMC practices, raise concern through proper channels, and support our colleagues who uphold the standard even when it's difficult. So it's a way of culture building where we are supporting those staffs who are trying to uphold this type of cultural values. Personal compassion fatigue. So when we have this type of fatigue, so what we should do, peer support groups, supervision, and self-care are not luxuries. So we have to understand this very fact that they are the prerequisite for sustained and respectful practice. Next slide, please. Okay, building a culture of respect in your ward. Here we can see that uh, individual actors matters, but culture is collective. So lasting changes require systems, not just intentions. So with this, we can see that there has to be team accountability where we have to hold each other gently accountable. A colleague corrected respectfully is a patient protected. Next is reporting mechanism. Know your hospital grievances process, and we have to encourage the patient to share the feedback and act on what you hear. Secondly, nursing leadership. Senior nurses can set the tone, model RMC behavior visibly, especially when juniors are watching. Peer support create safe spaces for nurses to discuss difficult case, emotional burdens, and ethical dilemmas without judgment. Next slide, please. Our commitment of going forward. So, here we have to remember the 7 rights. Number one, every woman, every shift, we have to be able to provide them dignity, and it's important that we take proper consent, give them proper privacy, and we have to ensure freedom from abuse, and these are non-negotiable. Then number two, use the Foxy resources, assess RMC guidelines, audit tools, and training materials at Foxy.org. So through this we can um, get these RMC guidelines, and those we can share with our team as well. Take a place. The pledge is I commit to treating every woman in my care with dignity, respect, and compassion that she deserves always. And number four, be the change. You are not just a nurse, you are a guardian of rights, a protector of dignity, and transformer of outcome. So, from the Foxy and yeah, that's it. And then, okay, next slide. This is again regarding communication skills and breaking bad news. A training program, which is again in continuation. We are going to discuss about how to develop our communication skill and how are we going to break a bad news. Next slide. Why communication matters? Because it helps to achieve better outcome. For that reason, we have to have clear communication, which reduces medication errors. And this is very frequently we are hearing this type of medication errors. So it also improves adherence and directly impacts patient safety and recoveries. So second is trust and dignity. Patient and family who feel that they are heard, they have reported higher satisfaction and greater confidence in their care team. And then frontline pressure. Nurses are often the first point of contact in crisis, yet they rarely receive a formal training in difficult conversation. So considering all these factors, we we understand that communication is a very important part of the hospital healthcare. Next slide. So understanding your audience. First thing is that language and literacy. We have to use simple local language and avoid medical jargon with the patient and families. We should try to avoid using very tough words which is difficult for the patient to understand. So in their local language, we should be able to make them understand the challenges or the situation that they are undergoing. Cultural sensitivity, we have to honor the family dynamics, gender, gender norms, and religious belief during the conversation. Then we have to see the emotional state. We have to be able to gauge the anxiety, denial, or distress before delivering any clinical information. So basically, we have to be sensitive towards our patient's emotion. And as we can see that every patient encounter is shaped by a unique human factor. So effective communication also helps in developing awareness. Next slide. Next slide. So what is the art of breaking a bad news? Here we can see they have set a spike protocol, like a setting. Setting means just choose a private, quiet space. Don't just discuss this type of bad news anywhere in uncomfortable settings. So just first sit down, ensure the key family members are present. Number two is perception. Ask the patient party what they already know. Like, what has the doctor told you so far? And this is, I think, since the sisters were expecting them to do this part also. Of course, not completely, but definitely they should know how to handle this situation because they are the first contact with the patient party. So they have to also discuss with the patient party that what the doctor has told you, and in I miss invitation, that is seek the permission, like are you ready to hear more about what we have found? Then knowledge, deliver the news in small plain language steps. Pause and check understanding, like what you are saying, you have to see whether they actually understand what you are telling them. And at the same time, we should not forget empathy, because acknowledge their emotions, and at time we have to maintain the silence. We should not just try to rush in to fill that pause. Take the pause, maintain the silence, give them time to understand the situation. And at last, summary, recap clearly, outline the next steps, and ensure the family is not left alone. Next, practice scenarios. Like now, we are discussing about some practical scenarios for breaking a bad news. So role play exercise build confidence and empathy before nurse faces these moments in the real world, like maternal complications, communicating postpartum hemorrhage or ICU admission to a new family. Second is fetal loss. These are the situations where we are going to, break this bad news. Like if a mother already started having bleeding, or we need to shift her in ICU, or there is fetal demise, which we all may have come across at some point of time. So we have to explain it very nicely with very compassion and cultural sensitivity. Or likewise, cancer diagnosis or any surgical emergencies that we are expecting. Next slide. And how to handle the grief, anger, and emotional outburst. So number one is active listening. Make eye contact, nod, and reflect back. Like, I can see how distressing this is. You can use this type of words. De-escalation, lower your voice, slow your pace, and move to a calmer space when possible. Set the limits gently. Acknowledge anger without accepting aggression. Involve the senior team also if it is needed. And self-care. Debrief with colleague after difficult encounters. Emotional labor is also very real. So you have to take care of yourself also. When you encounter this type of situation, you can always discuss with your colleagues, so that about this difficult encounter, because you have to also not drain yourself of emotional, too many emotional outbursts. Next slide. So nurse to physician communication. So this is again regarding how a nurse has to, communicate with the doctor in charge. So this there is a saber technique, SBAR technique, which actually just transforms simple vague verbal update into structured, confident, and actionable clinical reports. And the use of this is that it helps to reduce error and improve the response times. Like situation one, a patient is, you have briefed the doctor like Mrs. Sharma in bed 4 is showing signs of deterioration. So in the background, you should know the relevant history, the diagnosis, the current medication that she is taking and the recent vitals. So when you are reporting, then you have to also know all these parameters. And assessment, like I believe her conditioning is worsening. So BP is dropping and she is less responsive. So instead of this, you can go for like, uh, I, I mean, yeah, this SBAR. Okay, I'd like to little bit re state all these things. Thus, S is the situation. Like you have come across a situation where you see that this lady, she is her condition is deteriorating. So B is for background, where you have to see all the details about the patient. A is the assessment, like what you have assessed, like BP is dropping and she is less responsive. And R is the recommendation. So what is the recommendation that you can give to the treating doctor? Like I request you to review her immediately or advise a change in management. If in case you are not able to come, so some other doctors can come and you know uh, take the case. Next slide. Next slide. Yeah. So common communication breakdowns. Most adverse event in hospital involve a communication failure. This case study highlight where things go wrong and how to prevent them. So we are going to just elaborate few of these, like medication error. So most of the time verbal orders are given and which are misheard, and because of that they are reinforced by poor read back practices. Second is missed escalation. Deteriorating patient not flagged in time due to hesitation or unclear escalation pathways. So here also the problem happens where uh, we are not able to, the nurse are not able to actually give the proper medication in timing. And handover gaps, where we can see that incomplete shift handover, this can lead to critical informations being lost between the teams. Next slide. So we have to build a culture of open communication where we can see that daily team hurdles. So brief at least 5 minutes, word round at shift, start align the team, flag risk early. So whichever person is critical, you can inform your next batch sisters and build psychological safety as well. Next is structured handover. So according to the SBAR format, handovers at every shift change and never rely on memory alone for critical information. So most of the things is better that you note down, and when you are giving handover, you give all those things in writing. Next is clear documentation, which is legible, time stamped, and complete nursing notes protect the patient and staff alike. And the last is speak up safely. So foster a culture where every nurse feels empowered to raise concern without fear or hierarchy. Next slide. So what are the key takeaway and next step? So one is the spike protocol. So use the 6-step format for every difficult conversation and patients and families. Next is the SBAR reporting. So structure every escalation to physicians clearly by using the SBR technique. Next is empathy. Technical skill without compassion is incomplete. So listen before you speak, pause before you act, and practice role plays. Conduct monthly scenario-based drills within your ward team. Assess the Foxy resources that are available, download it and practice it, and champion change. Be the advocate for compassion, clear communication in your institution starting today. Next slide. So nursing excellence and ethics. This is again another program by Foxy and Amox, which is dedicated to empower the nurse with the values, principles, and professional conduct that define the world-class healthcare. Next slide. Setting the stage, why work ethics matter in healthcare today. The stakes are high, we all know. Nurses are on the front line of the patient care. Their decision, conduct, and values directly shape the outcome, trust, and the very reputation of the healthcare system. So, what happens without ethics? Patient trust goes away very rapidly. Team dynamics breaks down. Legal and professional risks are always increasing nowadays, and quality of care suffers measurably. So, next slide. So, the nurse code, which is the core principle of professional conduct. So, ethical nursing is built on a foundation of universal principle that guides every interaction with patients, colleagues, and the institution. So, beneficence always act in the best interest of the patient. Non malfeasance, that is, do no harm in action, word, or omission. Autonomy, respect the patient's right to informed consent. Justice, that is, treat every patient with fairness and without bias. And fidelity, honor commitments and maintain professional loyalty. So, this should be the nurse code. Next slide. So, here we can see that patient's secrecy and confidentiality that we have to safeguard the trust at every step. So, what confidentiality means in practice? That means every detail that is shared by the patient, including diagnosis, history, family circumstances, is a sacred and protected. So, disclosure without consent is a breach of both ethics and law. So, do not share. Assess only when you need. So, this record should have limited access to only limited peoples only, and seek the consent. Always obtain permission before sharing information, even with the family members. Next slide. Next slide. So, see, now we are going to discuss some real life scenarios, like why confidentiality is very important. So, we can see that ethical dilemmas are not always obvious. Recognizing them in the moment is the first step to respond correctly. So, number one, a curious colleague, like a fellow nurse asked about a VIP patient's condition out of curiosity. So, in that situation, what are we going to do? Our response should be like politely just decline, and you can tell her that you need to know applies to everyone. And secondly, if there is some insistent family member, a relative who demands a full diagnosis report without patient's consent, so you just tell them that direct them to the treating doctor, but do not disclose about the situation or condition of the patient to the patient party. The social media temptation. A dramatic case feels worth sharing online. Many times some babies are delivered and the baby is very looks abnormal. So in those situations, we uh, somebody they can take photo and share it online. So these type of things need to be avoided. Then we have to respect in the workplace, that is honoring the colleagues across their ranks and roles. And why mutual respect is non-negotiable. A respectful word is a safer word. Research consistently show that teams with strong interpersonal. Uh, I think my slide is gone. Hello, am I audible?
Yeah,
Just a
yes,
second, sir.
sir.
Give me a minute. I'll reshare it, sir.
Yes,
In the
ma'am.
meantime, you can still continue talking, sir. We will share the slide from our end.
Yeah, I can just.
The slide is visible, sir, now.
It's yeah, it's visible. Yeah, thank you, madam. So respect in the workplace. So as I said that it is non-negotiable. So respect in action also should be there. Address our colleagues by preferred name and designation. Never undermine a colleague in front of patient, and that is very important that we should not let our uh, sisters or any other staffs of the hospital, they should not be, abused in front of the patient. And we have to acknowledge contributions at energy. I mean, acknowledge contributions at every level, even from ward boy to top till the consultant. We have to appreciate everyone for their sincere, work. Speak up against bullying or harassment without hesitation. So if anyone is bullying their juniors or harassing them, then they need to speak up. Next slide. Upholding the nursing profession, which is the pride, accountability, and the dignity. So pride means representing, since you are representing a noble profession, so that you have to be proud about. Accountability, that means you have to owe for your own actions. Like if you have committed any error or if there's scope of improvement, then dignity, maintaining your composure and self-respect. So these are the pillars of nursing care. So what professional in identity looks like. Nursing is one of the most trusted profession in the world. Every nurse carries that legacy forward through daily choices in punctuality, appearance, communication, and the quiet courage to do what is right, even when it is difficult. Next slide. Legal and ethical framework, what Indian healthcare law says. So, nurses in India operate within a robust legal and regulatory framework. Awareness of this is not optional, it is a professional obligation. So, what are the laws? One is Indian Nursing Council Act 1947, where the government registration, standard of education, and professional conduct for all the nurse across India. Next is IT Act and data privacy. Uh, Sharing the patient data digitally without consent may attract liability under the Information Technology Act 2000. So this is also some important law that most of us are not aware of. But if you share this patient's privacy digitally without their consent, so you are again liable for punishment. And Consumer Protection Act. Patients are consumer, so negligence or misconduct can result in legal claims against the nurse and institution. So these are, to know these laws, it's not optional, but it is a very important professional obligation. Next slide. Next slide.
So your voice is
Yeah,
not
yeah.
audible.
Yes, 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 yes. Building an ethical ward culture. So practical steps for daily practice, which means reflect, act, speak up, and review, and place and way forward our commitments to ethical nursing care, where we have to protect the confidentiality. Every patient's story stays sacred, and we have to respect all. That means the colleagues, the patient, and the other profession, and we have to act with integrity, always, even when no one is watching. Next slide. And 1 second. And this is the place that is I solemnly placed to practice my profession with conscience and dignity, to hold in confidence all the personal matters committed to my keeping, and to uphold the honor and noble tradition of my profession. This is the place that they have to take. And on this regard, we thank every nurse for their dedication and invite continuous learning, reflection, and growth in ethical practice. Next slide. Yeah, thank you.
Thank you, Sunil sir. That was very, very nicely. I hope this was a useful session for all the staff nurses that are there. Once again, I would like to thank Dr. Kevin sir for being there throughout, Dr. Tejavu ma'am for being there, Dr. Apeli ma'am for the very nice elaborate talk earlier, and to Sunil sir, in spite of the emergency, he's finished it and he's joined and he's given the talk. Thank you, Sunil sir. Thank you, Dr. Monica, Dr. Lungan, for coordinating the whole thing. Thanks to all of you. Hopefully, this benefits most of the sister nurses. If there is any query by any one of you, you can directly contact us to all the sister nurses anytime we are available. Thank you to all of you. Dr.
Thank
Lungan,
you.
if you want to say
Yes.
something, please go ahead.
Ma'am, nothing to say, ma'am. Ma'am, you already said, and I'm really thankful to Kevin sir and the Kohima and Obstetric Gynae Society. They have responded very well and with a huge number of attendant participants. Thank you, sir, and
Thank you,
thank you.
sir. And thank you, Sahiti, for providing the platform and for constantly changing the slides with us. Thank you so much.
Thank you so much, each and everyone
Yes.
from Foxy, from the members who have participated, and the speakers. I would like to say in the end that actually childbirthing and obs and gynecology is one of the most emotionally charged department in all the medical science. And it is not only the doctors, but the nurses and all, even OT staff, then sweepers, and all these things are responsible in bringing a peace and harmony to the patient. And any word or even a slight gesture can prompt the patient to go to extremes. So it is very important, such an important discussion on medical etiquettes, not only for the nurses, but even for the doctors and for all the staff of the hospital. I thank you once again. And through this learning, we continuously learn something new every day. Thank you, each and everyone, for your patient participation. Thank you. Thank you,
Thank
Thank
Lorenzo.
you so much, sir. From the
Thank you.
association, on behalf of all the three committees, I thank Kohima OBGY Society and Sahiti. Thank you so much for the technical help. Shatabdi, thank you for coordinating.
Thank you all. Thank you.
Good night, ma'am.
Thank you. Thank
Thank
you,
you.
Mr.
Thank
Dev.
you. Thank you
Thank you
so
so
much,
much for
each and
joining.
everyone. Thank you.
Uh, you will receive your certificates by the end of 2 weeks.
Okay. Thank you, ma'am. Thank you, ma'am.
Thank
Good night, everyone, then.
Good night, sir.
Thank you so much.
Thank you, sir.